Hello, everyone. This is Jeanette Gass from IASP, and I would like to welcome you to today's webinar. Today's webinar is one in a series related to the 2020 Global Year for the Prevention of Pain. I wanted to bring your attention to some information that appears on these slides before I introduce today's moderator. There are several ways to participate in the webinar. After the talks, we will have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be recording this webinar, and it will be available on the IASP website. You can also tweet using hashtag Global Year 2020 and follow at IASP Pain on Twitter. Now I have the pleasure of introducing our moderator, Dr. Karen Lawson. Dr. Karen Lawson is an assistant professor at the University of Minnesota's Family Medicine and Community Health and is co-director of integrative health coaching at the Earl E. Bakken Center for Spirituality and Healing. She is a physician board certified in both family medicine and integrative and holistic medicine. She was the 2003-2005 president of the American Holistic Medical Association and a founding diplomat of the American Board of Integrative and Holistic Medicine. She's been a student of integrative therapies and healing practices for over 25 years. Dr. Lawson is active in undergraduate and graduate medical education, teaches in the center's graduate courses, and since 2005 founded and co-directs the MA and graduate certificate programs in integrative health and well-being coaching. Karen is a co-founder and executive board member of the National Board for Health and Wellness Coaching. I will now hand it over to Dr. Lawson to introduce our speaker.
Thank you, Jeanette, for the welcome from IASP. It's an honor to be here today. I'd like to thank everybody for joining us from wherever you are, and to welcome our speaker, Dr. James Fricton. Dr. Fricton's been a powerful ally of mine and an innovator in helping advance the very important emerging field of health coaching. I've dedicated the last 15 years of my healthcare work to the development and evolution of health coaching through educational programs, standards development, delivery models, and outcomes assessment. And I share Dr. Fricton's belief that health coaching has the ability to change lives by empowering individuals and groups to take control of their own health, making belief changes and better behavioral choices to optimize their own well-being. An additional benefit in this era of COVID is that telecoaching has been shown to be just as effective as in-person delivery of coaching. So I'm so excited to have him share his work here today. Dr. Fricton is a professor emeritus at the University of Minnesota, senior researcher, Health Partners Institute, and a board-certified pain specialist at the Minnesota Head and Neck Pain Clinic. He was trained in medical anesthesiology and pain management at the UCLA School of Medicine and has 40 years of experience in patient care, university teaching, and National Institute of Health sponsored research on relieving and preventing chronic pain with the use of health information technology in patient care. With over 150 publications and books and grants with his most recent NIH-sponsored research on preventing chronic pain and addiction using telehealth solutions. Additionally, Jim lives his vision through his own life with passionate connection to his purpose, exercise, healthy diet, time in nature, play, and strong family connections. He's a lot of fun. You're invited to type your questions into the Q&A as we go, but we will save addressing them to the end of the presentation. So now take it away, Dr. Fricton.
Well, thank you, Karen, very much, and Jeanette for making this seminar webinar available for members of the IASP and others. And I am just sharing my screen right now. Can everybody see that okay?
I think we're good.
Okay. All right. Very good. Well, as Dr. Lawson said, my interest and passion has been focused on preventing chronic pain and addiction over the past 5 to 10 years, both NIH-funded research as well as publications and clinical tools that I've been working to develop. And so what I'm hoping to do is just share with you briefly over the next 45 minutes or so these solutions and how we're implementing them within our clinical practice. And so that's why I'm so appreciative for the IASP for making 2020 the global year for prevention of pain. We all know that chronic pain conditions are real, they're physical, and they are preventable. So the key is learning how to do that. Here's my disclosure information, NIH funding. I don't use any off-label use of medications, and I have a private practice. So the learning objectives for this presentation this morning is to describe the chronic pain and opioid crisis and how telehealth can help prevent it. And 2 is apply interactive telemedicine in clinical practice with implementation and reimbursement strategies, which is real critical to helping transform our healthcare system. And then finally, I'll talk about telehealth care programs in routine care with remote patient monitoring. And we all know that chronic pain is the big elephant in the room. We know that it costs in the United States alone $635 billion, estimated by health economists at Johns Hopkins. It is also the #1 reason people seek care. Mayo Clinic study found that 67% of all visits were related to some type of pain condition. And the most common chronic condition is chronic pain, as you can see, compared to diabetes, heart disease, cancer, and stroke. It's also the #1 cause of disability. And you can see this from the CDC, that arthritis, rheumatism, back, and spine problems are well above the other conditions that are contributing to disability. And it's also the #1 cause of addiction. And if you look alone just at the death rates compared to major catastrophes across the United States, the opioid crisis from 2000 to 2020 has had about almost 700,000 deaths compared to COVID-19, World War I, World War II, and the Spanish flu. So it's a very huge problem in our society. And we know that billions are spent treating it, but the question is really, how do we prevent it? So preventing chronic pain and addiction is something we all need to learn. It's important to recognize that over half of the individuals with pain condition at 1 month still have pain 5 years later. Now that is a telling fact that's very important to recognize. And many of these patients continue to seek care for the pain years after onset. And this failed treatment, delayed recovery, chronic pain and addiction is often due to patient-centered risk factors that are in the physical, behavioral, psychosocial realms of our lives that are not typically addressed within usual care. And this is something that we have to really do a much better job of. And so we need to consider ancient wisdom. Hippocrates, back in 384 BC, said it's more important to know what kind of a person has a disease than to know what kind of disease a person has. And so understanding the person really means, at least in healthcare, is knowing the risk factors, or broadly the causes of the condition, which is a characteristic condition or behavior such as poor sleep, poor diet, stress, smoking, that increases the possibility of illness, injury, and in some cases pain. And understanding also the protective factors, and in a broad sense, these are cures or factors that are characteristics, conditions, or behaviors such as exercise, healthy diet, that prevents or reduces vulnerability to developing an illness or pain. So what happens with risk factors in pain conditions is they do increase pain over time for a variety of mechanisms. Both obviously the onset may be an injury or strain, but persistence includes inflammation and tissue sensitization. And then of course at the nerve and spinal cord level, we have concepts of wind-up and convergence. And then at the brain level, it can be amplified with central sensitization. So risk factors sustain pain cycles. So once you have an onset event, this delayed recovery or persistence of the pain can occur as a result of these pain cycles that are set up between the risk factors that are in a person's life, whether it's poor diet, poor sleep, excess substance use, depression, anxiety, social conflict, work or home stress, burnout, accidents, injuries, poor postures, tight, tense muscles. All of these create these pain cycles that cause the pain to persist. And it's the combination of factors and the interrelationship between these risk factors that drives chronic pain. Now, on the other hand, protective self-care factors can create pain-relieving cycles. In other words, if you balance your risk factors with better posture, relaxed muscles, regular exercise, shifting to positive emotions whenever possible, healthy diet, sound sleep, having purpose and drive to really make sure that you recover from any injuries, self-efficacy, a sense of understanding that you control your pain problem, and optimism, or supportive social life and protective environments all play a role in creating this pain-relieving cycle that allows some people to heal after an injury, whereas the risk cycles and pain cycles cause other people to persist in pain after an injury. And so the Institute of Medicine came out with a wonderful report on relieving pain in America. And they state that the health professional's primary role for chronic pain should be guiding, coaching, and assisting patients in day-to-day self-care. But that's not an easy task. Unfortunately, self-care and prevention of pain is often neglected in routine care because, well, it's often not part of the biomedical model. There's inadequate time to train patients. There's lack of reimbursement for the process. Often there's an interference or regulation by health plans. Tedious electronic health record charting takes time away from our ability to interact and teach the patients. And we're inadequately trained in general to do this within our healthcare training programs. So how do we solve that problem? How do we create more of a transformative care program? And there are a variety of what we try to do within our clinical practice is to integrate treatment with training using telehealth. And so the treatment, we treat as usual, just like we would with any patient with pain, whether it's medications, therapies, surgeries, others. But we also integrate telehealth coaching to support the patient in achieving their goals, and particularly focus on reducing risk factors and improving protective factors. And it involves training and self-care to reduce risk factors. And we use technology for patient assessments, training, tracking, and remote monitoring. So the goal is really to use this transformative care model to transform not just the patient from pain and illness into health and well-being, but also transform the healthcare system in one that is really much more supportive of prevention and long-term success, particularly in managing the big elephant in the room of chronic pain. So transformative care is a very rare triple win. It will improve the quality of care, patient satisfaction goes up, it's better long-term outcomes of care because you're solving the problems that drive chronic pain over time. And it's lower cost of care. We estimated in some of our studies that's about an 8-to-1 return on investment for those health plans that reimburse transformative care. So telehealth care can be a critical part of transformative care. It helps improve access to care, provides distance-based care, supports patient-centered care, provides self-care support, and allows for us to remote monitoring patients and improve long-term patient outcomes. And I have done lots of telehealth care in the past year and a half, particularly during this pandemic. And here's a picture of myself doing a telehealth visit, actually, this is my daughter. She's going to medical school next year, Regina. So the types of telehealth programs, there's three major types. One is this interactive telemedicine, where patients and providers communicate in real time using HIPAA-compliant audio-video systems. And then we have these telehealth care programs, which include a technology platform, typically, that allows risk assessment, self-care training, and telehealth coaching to extend care into the daily life of the patient. And then lastly, there's also remote patient monitoring. We can monitor patients using both mobile medical devices and assessments to collect data on pain level, for instance, or risk factors, or sleep patterns, the blood sugar level, blood pressure, and a variety of other things. So I'm going to discuss each one of these three programs in a little more detail. So the first one is interactive telemedicine. And so there's a variety of different platforms out there currently. We currently use Doxy.me, but eVisit, Chiron Health, UpDocs, UCEDA, many others are available online and can provide a very wonderful experience in terms of promoting this telemedicine. So telemedicine features include, first of all, patients schedule a telehealth visit, as well as then receive reminder emails that include the links to the platform and the handouts. And my patients have found it very easy to use. Then we have a pre-call testing of the audio. Usually my staff takes care of that just for a few minutes, and the staff also documents what's their chief complaint, what are their goals today for the visit. And then the patient goes into a virtual waiting room for the patient until the health provider connects. At that point, once we connect, we can edit, triage, and change the sequence of patients within the waiting room if we need to. I try to stay on schedule the best I can, but sometimes multiple patients are in a waiting room. And staff really work with me on achieving that also. And then I also want to share my screen, particularly for handouts. So I use a lot of handouts to kind of explain the treatment plan. What are these pain cycles that are set up? What's their condition? What is causing the condition? And so I have a variety of different handouts, which of course I'm very happy to share with anybody who's interested to use within this telemedicine program. And we find that it's very simple to use for both staff and patients with a help center and secure messaging, and it's all HIPAA compliant. So we schedule a telemedicine visit just like we would schedule an existing appointment for an in-person visit. So they go right on the schedule, and instead of showing up in the waiting room, they show up in the virtual waiting room. And so prior to the visit, the staff emails patients the morning of the visit to confirm and get the informed consent regarding the virtual visit. And then once they send back, we don't have them sign it and send it. We just have them respond via email to confirm that informed consent. And then we send the link to them, to the telemedicine platform waiting room, and we test it with the patients, and the staff takes care of all of this. And then we send an email with any forms to be reviewed at the time of visit also, which includes diagrams, diagnoses, treatment planning, and self-care forms, things that I use in in-person visits also, but I share that with my patients for telemedicine. So I try to make everything identical to an in-person visit. And with the exception of the examination, and I typically do a virtual exam, and I have the patient, since I work with a lot of head and neck pain problems, the patient can kind of show me how the jaw's functioning, show me where the tenderness is within their temples or their neck, or if they have any sensitivities, anything like that, I can do that with a virtual examination. And then what I do is document after the visit, document the consent, the fact that it was telemedicine, HIPAA compliant, the time of the visit, and put in the SOAP note. And we bill in the electronic health record, the identical to how I bill with an in-person visit. I will also use a 99401 or 402 if I do any self-care. So I spend an extra 10 to 15, 20 minutes sometimes on what do they do to prevent that pain or to begin the process of healing. And I use the 25 modifier to indicate that it's a separate individual effort during the visit. Then I also use modifiers 95 for telehealth or GT for interactive audio and video. Now, let me shift gears a little bit. And as part of the telemedicine visit, I also implement a telehealth self-care program. And I talk about it during that 15 minutes and bill for it with that 99401 or 402. And telehealth self-care programs include telehealth coaching, pain and risk assessments. That is a questionnaire online and a platform. We train them in self-care with online micro-learning lessons. We don't have them participate in long 1-hour sessions of training. We realize when they're online, if they can have a 5 to 10 minute understanding of what to do, why is it important, and how to do it, it's much more helpful to be brief. Then we do remote monitoring of the pain and engagement within the program. And we also can engage family and friend support, social support, in addition to the coaching support. Now, let me go into a little more detail on the telehealth programs. So coaching is one of the new professions within the healthcare that is going to grow fairly rapidly because of the need for patients and providers and health plans recognizing that it's these risk factors that we really need to change in order to move towards health and wellness. So the National Board of Health and Wellness Coaching provides national certification for health coaches, and there are many programs, including the one that Dr. Lawson runs at the University of Minnesota to train health coaches. And the Personalized Activated Care and Training Program, which is at the website pactforpain.com, is an NIH-funded platform for implementing self-care and coaching. And there's many other programs out there that provide coaching. One is that I know with Becky Curtis is Take Courage Coaching at this website. So I can list many more, but it's one of those areas that I think eventually all health providers will sort of use health coaching to really support their long-term care of patients. So the telehealth coach extends care into the patient's life. So we can provide treatments within the clinic, but I really want to get into the patient's life and help make the changes that they need to really improve over time. This will help patients and achieve their goals. We provide telehealth visits, often weekly or bi-weekly, or whatever the patient really feels they would like to participate. We implement action plans. In other words, what do they do actually on a daily basis to solve their pain problem or improve it over time? And then we encourage adherence. The coaches improve success and outcomes. Also identify red flag conditions such as depression, abuse, suicidal ideation, and as needed, refer to a telehealth psychologist or back to their physician or other health professional. The clinical trials with telehealth coaching have shown excellent results long-term for the patients. And the red flags are a very important issue because often patients will not bring these up in our in-person visits, or they may not bring them up at the telemedicine visit, but the coaches are trained to help identify red flags such as mental health, such as severe depression, anxiety, suicidal, homicidal thoughts, abuse are each reviewed. We discuss with the clients and we tell them this is outside the scope of practice as a health coach, but they're happy to talk to their healthcare provider or to involve a clinical psychologist as needed. And then the confidential notes can be sent via the HIPAA compliant platform to the specialist or the health professional to just really engage in that. So it really helps us identify those patients that are going to have significant problems. Now, PACT is a platform that I mentioned earlier that I was involved in, sponsored by the National Institute of Health. And it's designed to really implement self-care training and routine care that's supported by a health coach. And so it does risk assessments, and it has a whole curriculum looking at whole person care to present micro-learning lessons, which are 5 to 10 minutes long, that really identify a specific risk factor and change it, help the patient understand why it's important to change it and how to change it. And it looks at all parts of a person's life. It allows online access anywhere, anytime by the whole team. And it is reimbursed by health plans currently. And you bill it and document in electronic health records just as you would any other medical record. So the research behind this was that we did a lot of research development that was NIH funded on what are the risk and protective factors that are driving chronic pain. Then we did a conceptual evaluation of the course, one of these MOOC courses, which is a massive open online course, free. It's funded by the University of Minnesota. It's at Coursera, and it's on preventing chronic pain, a human systems approach. At that time, we also then submitted to take that content and put it into the PAC program for patient care. And Health Partners Institute and NIH funded this, and we did a randomized clinical trial. And we're in the process of doing a more broad scale pragmatic trial, but we are using this within the clinic currently. The scope of pain conditions that are included within the PAC program include back pain, hip pain, headaches, neck and upper back pain, jaw, facial pain, and shoulder pain, and others such as fibromyalgia in the future. So it helps us implement telehealth coaching and self-care and routine care. So here's the steps that we typically use for treatment planning. So within the telehealth or in-person visit, we have some treatment planning forms that really explain how this pain cycle works, how a protective cycle works, and how do we integrate training and coaching with treatment for the patient. And we can quick enroll a patient within the PAC program by the staff, and then we schedule the first coach visit. And within the platform, there's a whole, it's like an electronic health record only for telehealth coaching. You can schedule patients, you can do the billing, patients have access to all the information, including dashboards. That then the telehealth coaching provides a support. There's online self-care micro-learning lessons to reduce those risk factors. It's personalized based on the risk assessment, and we can track patient-centered outcomes also. And like I said earlier, it has access anywhere, anytime by your phone or by a website. And the billing system can be integrated into the electronic health record pretty easily. And so the patients do complete the micro-learning lessons. And as I mentioned, it's personalized. So they're 5 to 10 minutes, and it uses kind of a cognitive behavioral therapy training program to not only, but to reduce risk factors by implementing protective action. So it's not trying to get rid of something. It's really tried to implement healthy activities that have a potential for improving the pain condition, like stretching exercise is a good example. And it includes personal stories of real people. The daily action plan includes these 3 parts: healthy habits, pauses, and calming practice. And the patient documents the progress over time so that the coach and the health professionals and the patient can monitor that over time. Here's the list of different lessons that are focused, again, on developing protective actions on a daily basis. And there's one module on understanding pain and all these cycles and self-care, immediate self-care that heals, like heat, cold massage, exercise, analgesics, lifestyle, and stress and strain reduced. And then the 7 areas, realms of a person's life. How do you shift to optimism, feeling of self-efficacy to be able to control your pain, having realistic expectations and resilience. Within the body realm, we focus on stretching, exercise, posture, and reducing repetitive strain. Under the spirit, we find that purpose is one of the things that drive patients to really recover and do what they need to do. But they also have a sense of self-compassion, feeling hopeful about their outcomes, and sometimes grit and determination because, as we all know, pain goes up and down. And then we focus a lot on lifestyle factors like a healthy diet, reducing sugar content, caffeine, substance use, improving sleep, and improving their activity level. And then emotions, we really want to reduce anxiety with calm, replace depression with happiness, or reduce anger and shame. And each one is focused on the positive emotions. And then social life talks about how important belonging in a social support network is really important, how work well-being and reducing social stressors, and environmental tools about how to be safe, how to protect yourself from infections, injuries, and other problems, and minimizing that risk. And here's an example. I'm not sure you'll be able to hear this, but let me just turn it on and give you an example.
We're so busy. Will help relieve and prevent pain. So I'm very practices in some of the most beautiful settings to help you learn how to do this.
I'm sorry if you couldn't hear that exactly, but that just is one of the animated videos that are provided to patients through this platform. And there's many other resources also that enhance patient engagement. For instance, access through their cell phone or computer. Many of the handouts, all lessons, also have a written handout that they can print out and follow. There are worksheets and daily logs they can follow, dashboards to track their progress, and a lot of reminders and alerts. And what we do to introduce PACT as part of an in-person or telemedicine visit is to provider evaluates patients and their pain condition. We discuss the diagnosis, risk factors, pain cycles, the 80-20 rule, which is we tell patients 80% of their success is based on what they do. And then we implement and talk about a more transformative treatment plan that integrates training with treatment. And we explain it in very simple terms. Treatment is more effective long-term if we also train you to reduce the causes of your pain. And of course, we always pose that question, are you interested in this? And most patients say, yes, I'm interested, but some patients do say, well, no, I just want the physical therapy just to see if it works. But I would say about 80 to 90% say, yes, I am interested in reducing the causes of my pain over time. But this does require a shift in the paradigms of care. So the paradigms that we need to implement within our routine care is the fact that we have to assume people are multidimensional. They don't have single individual problems with one cause. There's multiple factors that drive chronic pain. And thus we need to understand the whole person and shift to focus on self-responsibility. The 80-20 rule, 80% of your success, I tell patients, is based on what they do, and 20% is based on the treatments. And then it engages them in the self-care, but we have to provide that education and training to create this long-term sustainable change. And what that does is enhance the care process dramatically. It allows us to have strong partnerships and be realistic about outcomes and expectations. It'll empower and motivate the patient with patient-centered care and gather that social support that really people need to recover from chronic pain, any other illness, whether it's cancer, heart disease, and other problems. But with every condition, there's ups and downs, and we need to expect that. But let's measure the outcomes. Let's see how the patient's doing, not follow them up in 2 months to kind of get a retrospective view, but really track them over time on a weekly basis. And that's what a platform such as this allow. And these shifting paradigms and enhancing the care process will transform lives as well as the healthcare system. Now, one of the things that we understand that's critical within at least the United States healthcare system is that providers need to be reimbursed for self-care preventive services. So we've worked with the health plans closely to try to develop a strategy for which to pay for the time and effort that we do in implementing self-care preventive services such as health coaching, training, and risk assessment. So we use these CPT codes 99401 and 402. We also, health plans reimburse for telehealth coaching and the pain program and risk assessment using 99409. Now that's typically a CPT code for preventing opioid addiction and substance misuse. But they allow us and encourage us to really use it more broadly to prevent chronic pain and other illnesses within these types of programs. And then we also do remote monitoring to really understand the patient, what happens over time. So we have dashboards within this program that allows us to view their change in pain and severity over time, the impact that it has on their life, their goals, what is their current self-care and readiness for change. And we can exchange coach notes between the coach and the provider and see that progress over time. And we monitor pain, function, and engagement over time. So this is the pain, the worst pain, second worst, and third worst. And within each week or 2 weeks, you can see how the pain can change over time or get worse over time. So you have an ability to kind of monitor that closely. And this is for both the health professional as well as the health coach. And then we also do the risk assessment and show a risk assessment report about each of these areas of the person's life: mind, body, spirit, lifestyle, emotion, social life, and environment, and what their risk score is and some of the risk factors that may play a role, and what their protective score is on a 0 to 10, and some of the things that they do right now that are very helpful for them. And then we can track the patient's engagement also. For instance, the lessons completed, the action plan that they're following, the pain level, interference, and risk assessment are all available. And they have, based on the pain assessment, it also provides information, personal characteristics, pain level, history, goals, health professional information, their health coach, and the documentation of the visits over time. So most clinics, or many clinics, are interested in using a program such as this. And so we have a clinic implementation process. We're doing it slowly with selected clinics, but we're very happy to talk to any of you if you're interested in using this type of platform and coaching. You can sign up by sending an email to this or go to the website. We enroll providers, the staff, the billing staff, and the coach. And we like to match a coach to an individual clinic or group of clinics. And then PACT also offers training sessions to learn how to implement, team with a telehealth coach, and bill for services. And so all of this is provided as part of the clinical implementation process. So then finally, I just want to kind of go through a fictional example of a patient that has gone through, and I've had probably 300 or 400 patients gone through the PACT program with coaching, and this is kind of a little bit of a humorous fictional example. So Mona Lisa is a 37-year-old mother and wife from a wealthy family just outside of Florence. She was asked to sit still while a local artist, Mr. Leonardo da Vinci, painted her portrait to celebrate the birth of their second son, Andrea. Unfortunately, as a result of this sustained sitting, she developed pain when she sat still for hours at a time while the artist took his sweet time painting her portrait. So as a result of that, she developed headaches and jaw pain that was constant, severe, neck and back pain that's also constant, severe, and other symptoms, including dizziness, nausea, and stomach pain. She was not a happy Mona Lisa. So then she started sleeping poorly. She drank lots of wine, 6 cups of coffee per day to deal with the pain. She was not active, no exercise, trying to keep a smile on her face, but felt tense and irritable. She was becoming depressed. And she had a difficult time balancing her life as a mother and home responsibilities. She feels that demons have inhabited her, and she blamed her husband and her artist friend. And so the provider provided a telehealth transformative care program for her. Explained the treatment plan, prescribed exercises, herbs, monthly in-person visits. A telehealth coach supported her in self-care actions, including exercise, posture, reducing risk factors. A risk assessment and training helped identify those risk factors and implement a protective action plan. And her coach, patient, and provider tracked her progress over time over the next couple of months. The training program included focusing on understanding the whole problem, having realistic expectations and compliance. We wanted her to do exercise for muscle and joint pain, habit reversal, to improve sleep and dietary habits, reduce muscle tensing and repetitive strain, work with her emotionally on reversing depression, anxiety, and anger, and why she had those negative emotions. Also, working with her family and releasing this family and financial stress, and implement mindfulness calming practice every day. And create a home environment that was safe and healthy for herself as well as her children and her family. And so she worked on reversing this pain cycle. So she had improved sleep and energy, less chemical use, decreased muscle habits and strain, lower stress, positive emotions, and really better coping skills. And then after 6 months, Mona Lisa was happy and very calm again. Pain was under control. She practiced calming, mindful pauses throughout the day, developed healthy habits and exercise. Her mood, sleep, relationships with her family, and health were all better. So with that, I wanted to thank you for listening, and we're very happy to open it up for questions and comments at all. And I always like to leave this quote by Hippocrates: "The divine is the task to relieve pain." And within the slides, I do have a variety of different references that you can look up also if you get a copy of the slides.
Jim, actually leave that copy of the references up for a moment, because actually
Sure.
one of our first questions from your participants, which was, thank you for the lovely talk. And one of the questions asked was about that first NIH-funded research, the Health Partners trial. And if you have anything published on that they could access. And lacking that, what other references might help them in the development of a guideline for a program they're putting together in the Netherlands?
Yes, we have. Well, these references provide some of that information. We're still in the process of publishing some of these, but these are some of our publications that are available online. And of course, we can also, emailing me will allow us to send you the actual papers if they're interested also.
Great, thank you.
Thank you.
The next question that I have up was actually a question about any adaptations of this telemedicine model for use in developing nations.
Well, that's a very good question. Because it's a computer-based program, the ability to translate automatically is possible. And so within other languages, within other cultures, it is an online platform. And so it's very adaptable to other cultures, other countries. It's just the language barrier may be an issue, but we have had some patients, of course, with other languages, and they've been able to translate that. And the course that we have, the MOOC course, which is on Coursera.org, also has the ability to translate this information and knowledge into other languages.
Wonderful, thank you. Might be good to, maybe Jeanette can put that Coursera.org link into the chat for people, would be helpful. So the next question we have is wondering if there are any states that are using this specifically for injured workers and work comp kind of situations.
Yes, Bobby, that's a very good question. We are working with the University of Minnesota Disability Management Services and UNUM, the health insurance for disability workers, to implement this. We're at the very early stages. We have a grant that's will be submitted soon to NIH, but we also are very open to that. And we really believe that coaching can be very helpful for patients who are injured at work and to help them recover and get back to work and reduce those risk factors that may interfere with their ability to recover. So that's a very good question.
Great, thank you.
Uh-huh.
So looking for other questions from our participants. Said, will you be happy to provide your contacts? Well, yes, I believe your contact information, Jim, is on the slides, is it not?
I'm not sure if it is or not, but I can
Put that into the chat. You could perhaps put your email information into the chat.
Yeah, that's what
Yeah.
I'll do.
And I'll mention we did have one question in the chat. One of our participants was asking if all health coaches are medically trained. Are they doctors, nurses, psychologists, etc.?
Well, and I'll let Karen answer that.
Sure. Actually, no, health coaches can come from almost any background. There are a number of coaches out there who are nationally board certified who do come from healthcare backgrounds, not just medicine, but nursing, psychology, social work, pretty much all of the allied health area, a lot of nutritionists. And then there are people who do more extensive health coaching training who come from non-healthcare backgrounds. So for example, people from healthcare backgrounds will often do our post-baccalaureate graduate certificate because it's kind of an add-on or an expander to their already existing healthcare knowledge. Whereas people who come from other diverse fields of everything, literally from law, engineering, artistic oriented performing arts areas, then do a full master's program in the health coaching so that they can gain the healthcare knowledge that they need in addition to the coaching knowledge. And there's a very diverse field of coaches out there these days, which is why the national board certification is so important. And so if you're looking for a coach for yourself or for your business, I would strongly encourage you to at least look for people that have a designation after their name of being nationally board certified health and wellness coaches. There are, by the end of the year this year, there will be about 4,000 coaches nationally board certified. And if you're looking for training programs, the website for the national board, which I put into one of the question and answer postings earlier, actually has a directory of both approved programs as well as a way to find a health coach in your area.
Thank you, Karen. Yes, that's very helpful. And I have found, just as a pain specialist working with health coaches, that patients have a high degree of satisfaction in working with the coaches, and to have somebody support them with telehealth in their recovery has just been delightful for most of my patients. They just rave about the coaches that they're working with. And from my perspective, as I mentioned, it really does extend my care into the patient's daily life, and it's been such a helpful scenario for our patients.
Wonderful. We actually have a question from a participant who is a certified coach, life coach for chronic pain, and she's in Wisconsin, wanted to know how could she get involved with your program or the PAC program?
Well, she can email me, and I'm happy to connect her with some of the clinicians that are in Wisconsin or in that area. Although, interestingly enough, health coaches have, because it's all telehealth, can provide access to care from any place in the country to anywhere in the country. And so, but I'm very happy to kind of connect you with some of the clinics. And it's possible that health coaches, you can use this platform and work with a clinic. So if you know clinics that are, if you're a health coach and know clinics that may be interested in this, you can certainly contact us, and we can help you use the platform and connect with clinics, and the clinic then would bill out the services and typically pay the health coach directly. So the financial model has been worked out, and we feel pretty confident about it. Now we're applying it to other places around the country, and so we'll see how other health plans in other states do this. But I can certainly just send, within the chat, I did put my email address within there, so you could send me directly.
Thanks, Jim. Another participant wants to know if there's any chance or if you've considered adding remote monitoring of any physiologic markers, for example, heart rate, or I would say heart rate variability, or other physiologic indicators of stress and pain.
Yeah, great question, Serena. Yes, we were working with a technology company out in California to integrate physiologic monitoring signals like heart rate, sleep patterns, sometimes galvanic skin response, and other things that really measure a person's stress and other behavior patterns into the PAC program. We're not quite there yet, but that's one of the next steps that we have on our development process. Great question.
Great. And another participant would like to know, they're specifically interested in the risk and protective factors that you discussed, and wondered if you have done any kind of a systematic review around those factors.
Yes, Rob, we have. And we do present all of that data within the Coursera course, coursera.org. And I'll tell you, and if you just go to Coursera.
Jim, I put a link in the chat for everyone to the Coursera course.
Yes. And then just search preventing pain, and you'll find the course. And all of that, all the references are included in that. And it's all pretty well evidence-based. And they're not really systematic reviews as much as they are a collection of articles that support basically the same concept. Versus systematic reviews that I have done were more on clinical trials, but there are systematic reviews on health coaching, on things like mindfulness-based stress reduction, on exercise, on yoga. So there's a ton of systematic reviews of clinical trials on protective actions that patients can do every day that do work for pain. In fact, I was surprised, and I have a whole nother presentation on this, that some of the systematic reviews of these self-care actions show better efficacy than some of the passive treatments like medications that we have available. So it's pretty powerful data out there.
Great. There's another question here, and I'm not quite sure. George would like to know about doctors asking or making questions about or questioning their patients in this way, which I think, Jim, is something you did kind of allude to and talk about, and how critical the physician actually having those conversations, those introductory conversations that you alluded to. So I don't know if you'd like to say anything more about that.
Yes, I think that's a critical aspect of this whole transformative care model, is that we need to be able to have a dialogue with our patients, asking that specific question. I'm happy to, when somebody comes with me with a pain condition, I say, I'm happy to treat you with medications, physical therapy, chiropractic, and other treatments, but it's more effective long-term if we also train you to reduce the causes of your pain. Are you interested? And so that handoff is critically important. Health coaching should not necessarily occur independent of the healthcare system and the clinics. We think it should be integrated in, because that's when patients first, when you have a pain condition, headaches or back pain, you go to the doctor for that typically. And the doctor then refers you to a variety of different facilities to help alleviate that. So we think that this has to be integrated within our routine healthcare system, whether you're a primary care doctor, health professional, or whether you're a physical therapist, chiropractor, or a specialist. I think that this model has great potential to improve our outcomes, improve patient satisfaction, and reduce long-term healthcare costs.
Great, thank you. I'm not seeing any other open questions here. I don't know if there's any closing comments, Jim, that you would like to wrap up with in our last few minutes.
Yes, I'm just happy to say thank you very much for participating in this webinar and to support the International Association for Study of Pain in this global year of preventing pain. It's a very important concept, and there's lots of literature on the IASP website that you can access. And it's a really important movement, and I'm hoping that this provides at least an example of how we integrate prevention as part of our routine care for pain conditions. I think it's a model that is well overdue, and if we can get reimbursed and adequately, which we have found to be the case, it is something that could spread very easily to any practice. So I'm happy to help in whatever way I can if you're interested in doing this. And working with coaches is very important. Karen, do you want to say any final comments about health coaching?
Well, all I'll say is I did refer people to the NBHWC website. And I think it's really critical that if you are part of a healthcare team and you'd like one of your healthcare members to be, or your provider members to be trained as a coach, to really look competitively at the range of training programs out there. They do very, very widely. There are some that are specifically targeted to working only with pain patients. However, I would say any good, general, holistically oriented health coaching training program, which would include what we offer at University of Minnesota, would have coaches who are trained to be able to deal with patients in this population. So I just think it's really important that we look for quality training as well as quality delivery of services. And I'm also happy, I'll put my email in the chat. I'm also happy to be a contact if anybody has questions about specifically the health coaching training programs, implementation or evaluation.
Well, thank you very much, Karen. And thank you, Jeanette, also for participating and organizing this webinar.
Wonderful. Thank you very
Yes.
much.
Thank you
All right.
both so much. And thanks everyone for attending.
If there are other questions, I will respond to them using the question and answer dialog box too. So feel free to keep sending questions.
Thanks, guys. I'm moving on to my next Zoom. So thank you very much. You guys have a fabulous day, everybody.
Thank you, Karen.
Thank you both so much.
Thank you, Jeanette.